Okay, well, welcome to this NSWOCC and Wound Ostomy Constance Institute Continuing Educational webinar. Thanks for joining us from across Canada and around the world. My name is John Gregory. I'm a medical writer and journalist, and I have the honour of hosting this webinar brought to you by Perfuse Medtec. This Ask the Expert session concludes the Advanced Wound Strategies and Lower Limb series brought to you by Perfuse Medtec. So we look forward to a wonderful conversation with our three speakers. And before I introduce them, I have a few housekeeping items. We are recording today's webinar. So if you must leave a bit early, or if you know a colleague who would like to take advantage of it, then you can share a link to the on-demand on the NSWOCC website afterwards. We'll share that information with you. We encourage you to use the chat function in the Zoom toolbar at the bottom of your screen to let us know where you are. So I'm in Kitchener, Ontario. Where are you? Now, the Q&A function in the Zoom toolbar is better maybe to pose questions rather than using the chat function. We also have Jeff Forney also on hand to respond to any product availability questions in the Q&A at the end. But in the coming days after the webinar, you'll receive an email from NSWOCC with a link to the feedback survey, a certificate of attendance for today's webinar, and a link to the Zoom recording. So now, by way of introductions, let me introduce them. So Dr. Robyn Evans is the Medical Director of the Wound Healing Clinic at Women's College Hospital, involved in research and teaching. She's also a full-time family physician in the community. Dr. Evans is co-director of the Wounds Canada Champion Programme. She's the medical lead at Wounds Canada to support the development of interprofessional education programmes for clinicians. And then Dr. Gary Sibbald is a dermatologist and internist with a special interest in wound care and education. He's the founder and executive director of Woundpedia, as well as the project lead of Project Geko, Ontario Skin and Wound. Dr. Sibbald is a professor of medicine and public health at the University of Toronto, and Dr. Sibbald is co-founder and course director of the International Interprofessional Wound Care course, IIWCC. He's the director and director of the Master of Science in Community Health at Dalla Lana School of Public Health at the University of Toronto, and an investigator with the Institute for Better Health, Trillium Health Partners. And finally, he's the co-editor-in-chief of the journal Advances in Skin and Wound Care. And then finally today, Dr. Michael Stacey is a vascular surgeon who came to Canada in 2014 as a surgeon-chief at Hamilton Health Sciences and professor in the Department of Surgery at McMaster University. Dr. Stacey completed his medical degree at the University of Western Australia. He's the fellow of the Royal Australasian College of Surgeons, and he spent 2 years working at St Thomas's Hospital in London, UK, where he conducted research for his Doctor of Surgery degree. Dr. Stacey took the role as Chief Executive, Medical Executive, and Executive Vice President for Academic at Hamilton Health Sciences in 2018 until 2023. And Dr. Stacey has established in-professional diabetic foot ulcer and venous leg ulcer clinics in Australia and Canada. What an esteemed panel. So welcome Dr. Evans joining us from Sudbury, Dr. Sibbald joining from Toronto, Ontario, and Dr. Stacey joining us from Hamilton, Ontario. Now let me hand over the reins to Dr. Evans. Thank you.
Oh, welcome everybody. It's nice to see everybody from around the world, around Canadians. So this is Ask the Experts. It's the final wrap-up session, and Dr. Sibbald and Dr. Stacey and I will be available at the end of the presentation to answer any of the burning questions. This is the three of us as we look, or we think we look, maybe 30 years ago that Dr. Stacey pointed out, but nothing better than a little co-pilot to make us look younger. Next slide, please. So these are conflicts of interest, and if you just want to just read through these, they've been the same at each of these seminar series. Next slide. Okay, so what we want to do tonight is to review the evidence for the clinical use of geko and reflect on the previous discussions from the webinars that we've had, looking at best practice, new questions, and consolidate assessment and education on the topics of venous, diabetic foot, PAD, compression, improving wound care, dermatological pearls, and pain. Next slide. So what we're going to do here first is just review a little bit about the calf muscle pump activator, what it is, how it works. And each of us is going to take a short look at a couple of the studies that were done just to show where this muscle pump activator has been used clinically and some of the studies that show its evidence. Then we're going to do a little case, and at the very end, we're going to do lots of questions. We have some prepared questions and some from the audience. So the muscle pump activator looks like you see at the top of this diagram and the lady with the leg. So that pump activator sits on the peroneal nerve. It's easy to apply. Family members, patients can apply it. It doesn't take much training. There are great videos online to look at this. I've had no problems with patients applying it. It's very small, about the size of a wristwatch. It can be worn for 12 hours. Most of the time worn for 12 hours, but up to 24. So it can be taken off, put back on its container and kept overnight and put back on the next day. It delivers a pulse every second, which is not painful, nor is it bothersome to the patient. When they're sitting, they feel the twitch of the muscles, but when they're walking, there's no effect on this. And it's meant to stimulate the muscles in the calf, sort of trying to improve that calf muscle and venous flow up the leg and perfusion to the lower leg. Next slide. Now, is Dr. Sibbald here?
Yes, he is.
There you go.
Yep.
If you just want to talk about the physiological effect, Dr. Sibbald.
Yeah, so when this is put over the tibial prominence, you should be able to see the foot move upward and outward. There is activations of the muscles, and this will compress the deep vein, and it's equivalent to about 60% of natural dorsiflexion. In healthy subjects, the femoral artery blood flow and venous blood flow, volume and velocity on ultrasound. So what it's doing, and when we look at peripheral arterial disease and ulcers, diabetic foot ulcers or venous leg ulcers and diabetic foot ulcers may be neuropathic, ischemic, or neuroischemic. The femoral artery and tibial artery blood flow, the volume and velocity on ultrasound, and the venous flow, volume, and velocity on ultrasound is actually enhanced. And Robyn, do you want to go to the next slide? And here you see the baseline of the laser speckle contrast imaging. And this looks at the microcirculatory flow. And on the baseline, you see a slight augmentation locally that corresponds to the pulsatile flow. But with the geko, you see this enhancement. And in the wound bed, there may be as much as 225% increase in flux, and the peri-wound, 67% increase. And this really goes up the lower third of the calf, or what's called the gator area. And there is a note down there that patient had an active infection, and the area therefore had more flux than usual. So this increases over baseline is lower than expected. So I think what we are looking at is enhancement of flow. And there are many positive aspects to this enhancement of flow, as you'll see as we go along with the presentation. Next slide. This is really interesting. When you look at leg edema, and certainly the venous and the action leg edema, and this is a study during hospitalization post-kidney or post-kidney and pancreas transplants. And when they looked at leg edema with the geko device versus intermittent compression with a device, you actually see that the outcome, the leg edema was decreased more than with the intermittent pneumatic compression. And there was a significant p-value. There was also weight gain. There was a great urinary output total. There was higher femoral vein velocity. Complex wounds infections were decreased with the gecko compared to the IPC. We also had incisional wound healing in 104 patients that was enhanced, and the length of stay was 8.15 days instead of 9.3 steps. And when mobility, 80 patients had a pedometer, they were able to take more steps with the gecko than with the compression device. So the hospital observation is cost savings of $2,300 with the gecko device. And I think, Robyn, it does illustrate that there are many ways to mobilize leg edema, and whether it be compression, whether it be bandaging, whether it be stockings. And the gecko appears to do this with or without compression. You want to comment, or Michael, do you want to comment on that?
Well, I think if you think you've got edema that needs compression, I mean, generally the thing to do would be to add that. And then you add the gecko. I think it adds beyond what you'll get with compression. I think that's the key thing, Gary. But if people can't tolerate compression, absolutely use it because they'll get benefit from it.
Yeah. And I guess sometimes we do get in trouble with compression being painful and patients limiting the amount, or we're using suboptimal compression because of pain or other factors. Robyn, your input on this?
Yeah, I think it's always important to know where something fits, and we can, put anything on anybody. But I think the key here with this neuromuscular stimulator is that it gives us another opportunity to have something else to add to patients, whether it be for edema, pain, or arterial blood flow to aid in the healing process.
And Gary, just to add to that, I mean, the study that's up here is really showing you what happens with gecko when it's head-to-head with intermittent pneumatic compression. So this is showing you gecko without compression actually performs at a better rate than intermittent pneumatic compression, which is sometimes used post-operatively on patients who get some leg edema.
It's just phenomenal.
How often do you use that versus, say, putting thromboembolic stockings on?
Yeah, I'd say the pneumatic compression is not used that much because it limits patients in their mobility. I mean, stockings probably are used more often just because you can get up and walk around with them. But, equally, you can get up and walk around with a gecko. And for patients who can't tolerate stockings, then this is a good option to have.
It is really quite a phenomenal amount of edema and weight that was lost by just using the gecko.
Yeah, and the p-values were all significant, and this would be considered 221 patients were randomized, so you've got over 100, and that's better than a lot of the wound healing studies we often see.
Yeah, it's pretty powerful evidence for fluid management.
Next slide.
Okay, I think this is over to me now. So from the, what Gary's demonstrated in the previous slide, you saw what the physiological effect of the gecko is on improving both venous and arterial flow. And what Keith Harding and his group did in Wales was look at putting this into a randomized controlled trial in patients with venous leg ulcers to see what it actually does to healing, because there have been lots of studies that demonstrate benefit. And this is really just an overview of the study design. And what they did in this study was put patients or recruit patients into the study. And then they had a 4-week run-in phase where they all went into compression. And then after the 4 weeks, they were then randomized to continue with the standard of care compression or to continue with the compression and have neuromuscular electrical stimulation or gecko device added 12 hours a day. And that was continued for 4 weeks. And then they looked at the results after 4 weeks, and then they looked after that up to 3 months to see what the long-term follow-up was. So really a good, opportunity to see what this does in addition to compression. Next slide, thanks. And this is really just a summary. There's lots more data associated with this study, but if you look at the bar graphs on the left, what this shows you is the wound margin advance. So they've had a method of measuring how much the wound margin advances into the wound. And this is looking at the treatment group. So those in the grey bar had the standard of care compression in the run-in phase. You can see the rate of healing there, the rate of wound margin advance, that's in millimeters per week. And in the blue bar, you'll see what happens when the geko device is added, that rate of ingrowth essentially doubles. So there's a significant increase in the rate of healing. And if you look at the graph on the right-hand side, what you'll see there, this is the healing rates for the two groups combined together in the solid grey bar. And then the arrow that points at intervention is when the randomization happened and the one group received the geko. So the dotted grey bar shows what happened with the control group. They continued to heal, but they healed at a slower rate. And when you added the geko device, the rate of healing increased significantly. So this is really just demonstrating to you that, yes, compression is good, but if you add the geko device to that standard of care compression, you can actually speed up the healing rate. And this study looked at all comers with venous leg ulcers. We haven't shown the data here, but these were patients who, on average, their ulcers were present for longer than 12 months. And they're also large ulcers. The average size was just over 10 square centimeters. So not small ulcers, not short-term ulcers, but ulcers that, sometimes are a challenge to heal. So certainly this in venous leg ulcers demonstrates the real benefit of adding this to standard of care compression. For other types of wounds, arterial, diabetic, we don't have quite this level of data. We have cohort studies. We also have a lot of case studies that demonstrate benefit, but this is certainly a randomized control trial that shows it. And here in Canada, Holly Murray and her group have also demonstrated this with a cohort study compared to a retrospective historical study, a group rather, and also showed that the rate of healing doubled. So we go to next slide, thanks.
Okay.
On to you.
Yeah, thank you, Michael. That was great. So we did have a couple of talks on pain and how to manage pain in our complex patients. I just wanted to review this a little bit to incite some more questions for maybe the chat later on. So if we look at pain, we say the pain is what the patient says it is, and that was coined by McCaffrey. But we have background pain, or the pain from the cause of the wound, or incident pain, being that from things that make that pain worse. And then procedural pain are a lot of things we do at our patients in terms of debridement and cleaning the wound, even taking off dressings, cleansing, even type of dressings are all considered procedural types of pain. And then we factor in the complex issues of environmental, personal factors, many cultural and emotional factors. And all of these impact three types of pain that we all know to be either nociceptic, which is related to actual tissue damage, like hitting your finger with a hammer, or neuropathic, being that pain that's caused by the neurosystem damaging to nerves. And then nociplastic, which is a more complex type of pain that was really coined as a result of not being able to describe either nociceptic or neuropathic. And it was then described as nociplastic, which means there's not really actually tissue damage, but it's pain that results from altered perception. And many of us would compare this to things like fibromyalgia. But it's also true that pain that goes from acute to chronic can be somewhat like this nociplastic pain. Next slide, please. So just carrying on from Dr. Stacey's presentation on the study looking at rates of wound edge healing, there were secondary endpoints that were also done in this study looking at quality of life and infection. But one of the things they looked at as well was pain. So this is an ongoing investigational and something we need to look at more carefully about what the geko or neuromuscular stimulator does for pain in our patients. So it's the same study run in phase, and then they looked at the VAS, or the some way of quantitating pain, which VAS is the visual analog scale, probably most commonly used in research studies, and looked at that prior to the intervention for the 4 weeks, and then after the intervention. And you can see that thick line in the middle and the blue line on the graph are indicative of what the VAS, or visual analog scale of pain, was. And you can see once the geko device was put on the patient, the pain scores also reduced. So this is early work, and it's not a large number of patients, but it's certainly an indicator that there's more to be done with us. Pain, I think we all struggle with managing. We have lots of medications. We try to stay away from opioids, but I would say that you need more than one type of medication, or more than one type of modality to manage pain. And this is supported by the European Pain Society, that we need to use multiple types of modalities to manage complex pain. And this pain that is sometimes particularly difficult to manage is that of ischemic pain. Next slide. So using all of this stuff that we've talked about with the geko, I wanted to go back and bring it back to what is best practice. We want to make sure that we're using the right device at the right time. So we're just going to get Dr. Stacey and Dr. Sibbald to comment on this case as we go through it. This is a 56-year-old gentleman of mine who has sickle cell anemia. His walking is extremely limited because his hips have avascular necrosis, so he's quite bent over. Very little mobility in his hips and his feet. He's either in a walker or a wheelchair. Spend much of his day with his legs down watching sports. He's quite the expert. If I ever want to know anything, he knows it all. He has chronic ulcers, medial and lateral, both legs, and you can see it's just above the malleolar region. The ulcers are quite wet, significant swelling in his lower legs. He does wear compression. He's got a very good compression system on. His ankles are stiff. His arterial studies are normal. So we're just going to talk, how do we manage this? This is a patient where we're not really getting any activation of the calf muscle. His legs are dependent a fair amount of the day, and we need to know what we can do to make this better, given he's using the right dressings and the correct compression system. Next slide. So Dr. Sibbald, do you want to just describe some of the things you're seeing in the photo and your approach to this patient?
Yeah, okay. Thanks, Robyn. So what we're looking at is swelling of the lower leg, and you can see the tautness even when you look on the dorsum of the foot, and you can see, if you look at the skin up the ankle, you don't really see the malleolus very clearly. There is an open area. The lower one is most likely an ulcer. So that's loss of epidermis with the dermal or deeper tissue. Surrounding, though, there are smaller openings, and those smaller openings are most likely erosions. And that's a partial thickness where you've lost the outer layer of the epidermis, and they tend to be lighter, but you still have an epidermal base. There is hyperpigmented crusting, and crusts usually have either blood, serum, or pus. And this has most likely got a component of blood in it, and maybe serum. I don't see too much evidence of pus. And then there is keratin that's dry. And Andrew, if you point out the parts further out to the side where the skin is dry, and what you've got is hyperpigmented retention hyperkeratosis. And this is commonly seen when post-inflammation, and you've got a buildup of keratin on the surface of the skin, as you might see in something like psoriasis, but this is really different and is sometimes after the action. Hyperpigmentation often occurs when you have disruption of the dermal-epidermal junction. And that's where melanocytes rest, and so that you can end up with hyper or hypopigmentation. And you can also, this is an effect of melanin that is deposited if red blood cells might be involved in the process. And certainly in venous disease, they often leak out of the capillaries. On the next slide. Either I'm frozen or we're not moving. Andrew, the next slide. Okay, so under treating the cause for arterial circulation, you want to palpate the pulses, and I really use the audible handheld Doppler, and I don't know if the sounds are going to muffle out, but if you hear an inadequate sound, and this is when you hear shh, 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 and this is really when you've got monophasic type of blood supply. Any multiphasic one would give us adequate blood supply. So it might be biphasic or which is triphasic. For edema control, you might use appropriate compression. And if it's arterial disease, we sometimes start with a single layer of tubing grip, and when adequately fitted, it gives you about 8 millimeters of mercury compression. Keith Harding has pioneered some of the work in this, and you can have variable upper margins of this so that you're not getting a tourniquet effect, and they have been used up to 4 layers. It would depend on the pain, and it would depend on the amount of arterial disease. And you might even go on to higher compression. Check for anemia, and in sickle cell, anemia is quite common, and in checking with one of my patients that has sickle cell, his hemoglobin often runs with good nutrition between 88 and 92. We often want 100 for a hemoglobin of 100 for adequate blood supply to heal. We might consider hydroxyurea. And it's interesting, hydroxyurea gives us a higher level of fetal hemoglobin or hemoglobin F, and that tends to help prevent some sickling. And doses commonly seen of hydroxyurea are 500 to 1,500 milligrams per day. It does have an immunosuppressive effect, so that it has to be used with caution. And it does, in some ways, induce leg ulcers. And so this may be a problem. These patients with sickle cell often are susceptible to clots. And the superficial clots, often these patients may be helped with the apixaban or rivaroxaban, 2.5 milligrams twice a day. And doses go up to about 20 milligrams. I've certainly had some success in these patients with Trentol. And Trentol or pentoxyphylline is a xanthine, and it has an effect like caffeine, but it has 3 mechanisms that are sometimes useful here. One is it helps to work from the inside out and help to make woody fibrosis softer, so it's fibrinolytic. It is anti-inflammatory, and it does increase red blood cell contractility. These patients often have very severe pain, and the pain may be nociceptive, which is injury related, and this is where we might use acetaminophen. We often use 1 gram twice a day and sometimes go up to 1 gram 3 times a day. In Ontario, the 500 milligram tablet is covered on the Ontario Drug Benefit. Non-steroidal anti-inflammatories with extreme caution, and narcotics are sometimes necessary. But if you take the acetaminophen on a regular basis, rather than just as required, you may find that you can cut down on the amount of non-steroidal anti-inflammatories or narcotics. Neuropathic pain is spontaneous, and it's usually burning, stinging, shooting, stabbing. And this is where the gabapentinoids, Lyrica, which is pregabalin, or Neurontin, which is gabapentin, are often useful. And then I'll often use a tricyclic, a second generation, nortriptyline in very low doses, 10 to 30 milligrams at night. Then you can talk about using SSRI agents, or you can talk about CBD oil, sometimes combined with THC to help sleep. I think the most important thing, and I'll stop here, is to determine, is the wound healable? And I might have a different approach than if it's maintenance or non-healable, when you really want to control pain, exudate, smell, edema, and you want to improve the patient's quality of life. And we have seen in most of our leg ulcers, 2/3 are often healable. About 25% are maintenance. The patient doesn't cooperate, or the system won't provide what we need. And non-healable may be with distant disease or a negative protein balance, and of course, granulation tissues, protein. On the next slide.
So we could just go through, Dr. Stacey.
Yep, go ahead.
Given that this ulcer is we've got compression on, it's not infected, we've got the right dressing. What are the reasons why this ulcer is not healing?
Yeah, no, good question, Robyn.
Yeah,
so
go, Michael.
So I think what we should think about is what's the underlying physiological cause for this. So you mentioned two things at the beginning, Robyn, well, maybe three things. One obviously is the sickle cell disease, and sickle cell disease basically can result in occlusion of some of the small vessels just because of the nature of the structure of the red cells. So you get some degree of microvascular disease. The second thing is he's got fixed ankles. He doesn't walk very much because of his hips. He spends most of his day with his legs dependent. So essentially, he is sitting there most of the day with a high venous pressure. And you can see when you look at his leg, he's got the pigmentation, he's got the edema that comes from that high venous pressure. And the reason he's got that is because he's simply not using his calf muscle pump. So he's actually got a combination of functional venous disease plus small vessel disease in his arteries. So what you need to do to address this is to actually see what you can do to each of those. Now, he's having compression, but compression really in a person like this just helps with the edema. It does nothing for the ambulatory venous pressure because he's not walking. So what you need here is something to get the calf muscles to contract, to pump the blood up. And that's what muscle pump activator like the geko does. So that will actually help the venous return, which is one of his problems. And the second thing you need to is improve the microcirculation, knowing that he's got good large arteries, but his small vessels are the problem with some vascular occlusion, small vessel occlusion. And we know that if you add something like a muscle pump activator, you get this increase in microcirculation. And we've seen that benefit in other patients with things like scleroderma, with atrophy blanche, and also patients who have ulcers due to hydroxyurea. All of those have specific problems with the small vessels being occluded, and you can improve the microcirculation, you can reduce the pain, and you can get those wounds to heal. So I think and all the other things that Dr. Sibbald has mentioned, the other medications are all important. But if you're trying to treat the underlying key physiological problem that's contributed to both the ulcers forming and not healing, you do have a really good option in adding something like the muscle pump activator or the geko device for the reasons I've just outlined.
Yeah, I think that's excellent. Thank you, Dr. Stacey. I think one of the things we see a lot of patients that have legs that are dependent. So despite having perfect compression with legs that are dependent and no activation of the calf muscle pump, I think we get in this position where we really just cannot get rid of the edema for just those reasons, as well as that hard woody fibrosis. The local blood flow, as you pointed out, is really not that good due to venous ischemia, as well as just low blood flow to the area. So there's a lot of reasons why that leg is not healing. And this is better, and we can tell you a little bit why it's better now. So what are the other options if we go through the best practice guidelines of managing this type of venous leg ulcer with underlying sickle cell disease?
Yes, I mean, I think obviously you want to adhere to, the broad principles of, the time algorithm. So looking at, any devitalized tissue, which there's not a lot in this case, managing moisture. So you don't want things to be too moist, dealing with inflammation and infection. And Dr. Sibbald has spoken about a few options for that. And then ultimately trying to see if there's something you need to do to stimulate the cells in the surface of this wound. But the first thing to do in any of these situations is to look at what's the underlying cause. And that's where you've got a combination of venous problem here with venous function not working, and you've got a problem with the microcirculation, with the small vessels being occluded because of the sickle cell disease. So treat that cause. You've used compression, you add a muscle pump activator, you increase the microcirculation, increase the venous return, lower the venous pressure. If you're still not getting improvement, then you've got to work through stepwise, the other types of opportunities that we have with different advanced dressings. So things that deal with bacteria and biofilm, things that maybe inhibit excess protease activity, something that's going to stimulate granulation tissue in the base, either negative pressure or a matrix substitute. You may ultimately think of adding growth factors, not that we have too many options. And then finally, you may think of adding cells, because ultimately it may just simply be these cells are so damaged from all of that tissue hypoxia and inflammation that you need new cells to get this wound to heal. So working through, and I think although this patient is not just due to venous disease, he fits very well into the structure of the Canadian consensus statement on the management of venous leg ulcers and how you approach that. Because he's really a combination of functional venous disease and microvascular disease from the sickle cell anemia. So working through those steps is really critical. And then ultimately, I think, doing all of those things, you've got an opportunity of taking this patient from a challenging situation of it not healing to getting it to heal. That's my approach, at least, Robyn.
That's great. I think the physiology is where it's at. Dr. Sibbald, do you want to add to that? Next slide.
I think we put you on mute, Gary.
Sorry. I think in the early days, there were a lot of failures in these patients trying to use living skin equivalents and using other types of acellular matrices. And I think this is where wound bed prep came from. And, with a hemoglobin of 88 to 92, you may not have the oxygenation in the skin that's required for healing in these patients. And I think a lot of things happen. Out of curiosity, Andrew, is the other slide in there that I inserted? Okay, this just shows the kind of change that some of the sickle cell patients get when they get occlusion of the small vessels around the base of the foot. And you can see where you've got something much like atrophy blanche. And I think this is small vessel occlusion. And this patient did have those problems. And go back one. And this is more like what you would see with the patient that Robyn showed, where you may have venous disease, but it's not completely typical of a venous ulcer, and you don't really see healthy granulation in the base, but there's several reasons for this. Robyn, do you want to add to that comment?
No, I think that's pretty good. I struggle with these sickle cell patients because there's so many complex factors, as in terms of blood flow as well as healing potential and edema, that make it very, very difficult for them to move forward. Next slide.
Yeah.
Okay, well, I think that really demonstrates, we've looked at the gecko and how it manages some of the properties of edema. We've used it to accelerate healing with venous leg ulcers, and partly demonstrated some use for its pain properties, which may be a result of reducing edema and advancing wound healing. But nonetheless, it seems to have an effect and is worth looking into it more. But as the gecko becomes more and more available over time, it's important for us all to use it appropriately, not put it on everybody. But I think we have to think of the pathophysiology, looking at that case and Dr. Sibbald's and Dr. Stacey's comments on the physiology and what caused the ulcer and what we're actually trying to achieve at the wound bed. We wanted to open this up to questions now because it's supposed to be asked the experts. So we'll love to see some challenging questions that we can all learn from.
Okay, we have some questions already. But Dr. Evans, Dr. Stacey, and Dr. Sibbald, thank you very much already. Farah, you have inundated me with questions. I've got questions also from Mark and Sue, and seen one from Josephine in the chat as well. Maybe more around kind of the clinical questions, given our experts. So Farah asks, should you do an ABPI before use? Dr. Sibbald, maybe that one is for you. You talked about palpating pulses and use of the audible handheld Doppler earlier.
I think you should know the ankle brachial pressure index. I haven't done one in 10 years, and I'll let Michael comment. I really do use the audible handheld Doppler. And, it's kind of interesting that I do have one patient that did have some advantage to the gecko. And his, after about 6 weeks of gecko, he went from having a monophasic sound to having a biphasic sound. And I think that it is useful having documentation. And the other documentation, just because we're talking about things you might measure, was that my patient with sickle cell used the gecko for a month. And when we actually measured the muscle in the leg with the gecko versus the leg without the gecko, he had about 1 centimeter more of tissue, and you could actually see a clinical difference in this in his leg. So it might be doing the same kind of thing that you get with exercise and conditioning. So I think looking at clinical parameters, expected and unexpected, might be useful. And Michael, nobody really exercises for 12 hours a day. Right. And maybe there is a sustained effect of some other factors that, even in Keith's study, really helped for healing.
Yeah, so two comments from me. Firstly, just for all of the people in the audience, if you've got a patient with an ulcer on their leg, in this day and age, you should get some assessment of their arterial flow, because feeling pulses is not always as accurate as you think it is. So you either, in most cases, if you can access an ABPI, you should get that. If you can't, then looking at a handheld Doppler, as Dr. Sibbald has mentioned. Just because you can sometimes be fooled by these patients. You think their arterial flow is good, but actually it's not. You may or may not correct it, but it's important to know that, because ultimately you may need to correct it. And the second thing is the comment about, when you think about why does gecko do better than just compression? And the reason is, and Gary alluded to it there, Dr. Sibbald alluded to it there, is we recommend patients with venous ulcers wear compression and go into an exercise program, but they don't exercise 12 hours a day. And what happens with the venous pressure is when you're sitting or standing, your pressure goes back to a high level. The way that the ambulatory venous pressure improves is when you're exercising, the pressure drops. So if you're just sitting there, you ambulate maybe for half an hour and you go and sit, your pressure goes back up. But if you've got a muscle pump activating all the time, it's keeping your pressure lower. So if we're trying to understand why it should do better than compression alone, the answer is because your muscles are contracting for 12 hours. So it's actually reducing the venous pressure for a much prolonged period, which then helps the healing physiology which is why in the studies that have been done to date, it actually doubles the rate of healing. So, there's an underlying simple explanation for why it actually improves healing better than what Hippocrates used to recommend to his patients, thousands of years ago.
Thank you both. Sarah asks, for lower leg wounds, is there a role for nitroglycerin patches applied to the peri-wound to improve circulation?
Dr. Sibbald actually prepared a slide on that because I saw a lot of questions from previous talks on this. So do you want to just pull up that slide?
Yeah, you can pull up that slide. So I think it's interesting. Nitroglycerin does facilitate vasodilation when absorbed into the body. And it helps by releasing nitric oxide. And in sickle cell, some of the sickling is probably due to the fact there is a low nitric oxide level. It also relaxes smooth muscle in the blood vessel wall, the endothelial cells, widening arteries and veins. Now, there is a random controlled study that by a group of podiatrists that 11 patients had nitroglycerin patch and 11 had placebo. First of all, the patch was 0.2 milligrams per hour, and most of the time we need a 0.4. And they used the 0.2 because they didn't want to influence cardiac pressure, etc. And if somebody has normal arteries, and I might defer this comment to Michael, I had a nitro patch put on my arm by a rep, and I forgot I had it on there. And about 2 hours later, I had the worst headache I've had in my life. And, so that there are some side effects to having a patch that's stronger. And if you don't have any arterial disease, it might cause things. They put the patch on the arch or the side of the foot. It's best on the dorsum and rotating sites. 11 subjects each had patch or placebo, so it's a small number. These were normal volunteers, and perhaps persons with sickle cell and other patients with leg ulcers do have reduced nitric oxide, and this may be more suitable. One example is persons with diabetes, and a second is sickle cell. And they used it for 2 hours, and usually if we use a nitro patch, it's 12 hours on and 12 hours off. Michael, help me out on this one.
Yeah, so just so people understand, so with a nitroglycerin patch, I mean, it's not just effective where you've got the patch. Basically, you put it on because it's being absorbed into the system. And that's why, Dr. Sibbald got a headache, because it was there dilating the vessels elsewhere. So essentially what it does, it helps the vessels to dilate, but it'll have an effect just beyond where you've got the patch. In fact, it can have a systemic effect. But what you're looking for is an effect on those vessels that have got a degree of spasm, or that have got a lot of occlusion, and you're wanting them to dilate. And maybe just, by way of example, like we use 200 micrograms of nitroglycerin, which is the same dose as your 2.2 of a milligram. We use that intraoperatively when we do angioplasty on small vessels in the leg, because they tend to go into spasm just from angioplasting or ballooning them. So we inject that into the arteries, often just before or sometimes just after we've done an angioplasty, to enable them to dilate. So it's a very good vasodilator. If you use it, you've got to be aware that its effect will be more than just locally where you put it. That's the one caution you have to have with this. But that's why it works in people with heart problems, because they take it and it enables vasodilatation of the cardiac vessels as well.
Wonderful. Thank you. I have another question from Mark, and then actually a group of questions, maybe diabetes related or diabetic foot related. So Mark said, has anyone measured transcutaneous oxygen or at or around the wound site with geko on versus off to determine whether and how it increases tissue oxygenation?
Good question. I can speak to it. I don't think that I've seen studies that have actually shown that head-to-head, unless maybe Jeff Forney or Kathy Burrows know of some studies. But what we do know, from a lot of studies using transcutaneous oxygen, is that when you do things to improve the arterial flow, there's a lot of data that it actually increases transcutaneous oxygen. And so that's small and large vessel disease. I don't know that it's specifically been done with the geko, but I would anticipate, given what we see with the laser speckle contrast imaging, which is showing you that increased microcirculation, I'd say 100% that you would get the same increase with transcutaneous oxygen monitoring, because what that does, it's also effectively measuring the microcirculation and the oxygen transfer. But maybe Jeff or Kathy, anything you're aware of that could speak to that?
I know we've studied it, but I can't remember if it was on the wound site, and I can't remember the data off the top of my head. So I'd be happy to get back to whoever asked the question with an answer. I just don't have it off the top of my head.
Yeah,
I think it
Mark.
would be
So
very interesting, Jeff, to have that measured, say, in the sickle cell patients and some of the other, venous and some of the other cell populations, just to see what it does on the surface. In Ontario, that modality no longer has a fee schedule, so that even with hyperbaric patients, it's often not done. And I think it is useful, but it is finicky, it is costly. Michael, I think the machines might be something like $20,000. And if you don't have experience and you don't calibrate the actual the port that goes on the skin, you can get false values.
Yeah, so they're a little bit cheaper than that, Gary, depending on how many probes. I've used it a lot as a research tool over a long period. It's really more a research tool. It hasn't really created reliability as a clinical evaluation tool. But if you think about it, it's just simply another way of measuring microcirculation, and that's why the laser Doppler has really replaced it. And the laser Doppler, the one you saw there, is a laser speckle contrast imaging. That's giving you a broader image of the whole area, but the standard laser Doppler probes just sit in one spot and they measure the microcirculation. So it's effectively the same measurement that you're getting with laser Doppler. So the fact that you get improvement with laser Doppler, I would say almost certainly you would get improvement with transcutaneous oxygen. And like just as an example of what can influence, your transcutaneous oxygen measurements. So when we used to do this with patients, we always sat them down, lay them down quietly, let them settle, and then you get a baseline. If you start talking to them, their transcutaneous oxygen levels go up because that's right, because their minds are working, they may start breathing more, they may start speaking back, and just that increase in microcirculation flips up their transcutaneous oxygen reading. So
Amazing.
Something like geko, which does much more than that, would almost certainly do the same thing.
That's fascinating. So as noted, we have a number of questions, diabetes related. Martina, you asked, can this be used on wounds that probe to bone?
Who wants to take that?
I don't see why not.
Yeah.
Yeah, there's
go ahead, Robyn.
No, I don't think there's any reason why not. There's very few contraindications to using the geko. And if you're just trying to improve blood flow locally, I mean, with our diabetic foot patients and ulcers, their local blood flow microcirculation, again, is not good. So anything you can do to reduce the edema and improve the vascular supply is going to be good. And there's no reason, even if it probes to bone.
Okay.
Yeah, and I think if you are probing to bone, obviously the concern there is whether you may have osteomyelitis and bone infection, which you want to assess that and treat that appropriately. But there's no reason to not use this. I mean, it will help all the tissue around that wound to actually improve. So there's really little or no contraindications to using this device. And where you've got situations where you're not getting a lot of benefit, there's very good reason particularly with wounds on the leg, to think about, using it.
Yeah, I think it's always important to go back is look at the cause, make sure you're addressing the cause factors, and think about what you're doing when you're putting on something like this, and is it required? So if blood flow is the issue and edema is the issue, there's certainly, this is something you should use in your toolbox to help accelerate healing.
Okay, so maybe a related question: can it be used after toes have been amputated to prevent further amputations?
Okay, I can jump to that one if you like. So, as I'm a guy who does amputate toes, so basically we do use it in that group of patients. In fact, it's primarily to try and help the amputation site to heal. So sometimes we do it after we've revascularized, we do an amputation. They've still got compromised circulation, so you really want to ensure that that wound will heal. But then we've also been using it in combination with Dr. Meyer in his wound clinic in Hamilton. When patients who've got no other revascularization options, they may have just a single or a couple of necrotic toes which need to be removed. But you don't want those wounds to deteriorate. So we do it in combination with removing the toes, adding the geko to try and ensure those wounds heal. Because if things deteriorate, your only other option is a major amputation. So 100% very useful in that group of patients.
Okay, so again, around diabetic foot ulcer, you mentioned, Dr. Sibbald, Trental pentoxyphylline.
Pentoxyphylline, yeah.
Thank you. 400 milligram TID. Have you or do you use that with diabetic foot ulcers?
Yeah, I do. I use it probably more with the venous ulcers, and often, and I might deflect to Michael here, but my son, who's an interventional cardiologist, tells me there's no contraindication for using pentoxyphylline if the person's on an anticoagulant, but often, depending on the diabetic foot ulcer, and if it's ischemic, it might be more important for them to be on an anticoagulant. And I would see the pentoxyphylline as a secondary thing in maybe selected patients. But Michael, help me out there.
Yeah, so I think one of the reasons that pentoxyphylline works in a lot of the patients who've got a leg ulcer, and Dr. Sibbald, referred to earlier on some of its modes of actions. But one of the things it does, it actually has an impact on the red cells and makes them a little more flexible, so they can actually get through the small vessels. So sometimes these vessels have got a degree of sclerosis. Sometimes they've got a bit of, inflammation around them. So the normal red cell has difficulty getting through. So if you make it a little more flexible, it can get through and it can provide oxygenation to the tissue. So certainly as an adjunct to your other treatments where you're treating the underlying cause, and to Dr. Sibbald's point, if you need anticoagulation, use it. But adding this is just another little extra thing that can help to improve the circulation in those compromised small vessels. And it's also where, adding in something like the muscle pump activator, it increases the blood flow and helps that as well. So you've got a number of different tools available to you. And if your problem is impaired microcirculation, then you should look at each and all of them, particularly if your patient's wounds are just not healing.
Okay, thank you very much. I know I can see that we're coming up to the hour. I have two particular questions maybe that I would like to pose to our expert panel while we have them. And I know Jeff Forney is responding to a couple of others either in the chat or the Q&A. So I think it was commented earlier that maybe you shouldn't use a geko for more than 24 hours or 24 hours a day. Can you explain what the logic or reason behind that is?
Yeah, I'm happy to jump in on that. We actually did dosimetry studies because we do have one side effect with the device, and that's a rash formation under the device. And we did, and we're working on mitigating that and more to come. But the dosimetry study was done between 6 hours and 12 hours of therapy, and 12 hours turned out to be more effective. But at 24 hours, we had more rash. So the idea is there's no magic to it. We still need to work on it, but 12 hours was chosen based on that.
And if I
Yeah, no,
can just
thank you.
add in, like in patients in whom you're using it who've got more of an arterial or a microvascular cause for it, there isn't really good data on how long you should use it for in those patients. Like we have Keith Harding's study that's, shown us that if you use it 12 hours a day in patients with venous ulcers, it's definitely beneficial. Patients with arterial ulcers or those, the atrophy blanche or even, your sickle cell disease patient that was here, they have exquisite pain and their pain is often worse at night. So sometimes with those patients, you're better off using it at night rather than during the day. We don't yet know what's the optimal time to use it for in those patients, but when they've got their worst pain is often when you want to use it.
So can I just add one more point here is that the 12 hours dosimetry, if you think about the fact that the device delivers 60% of the blood flow of continuous walking, that's like a 7-hour walk. So that's a massive amount of blood flow by comparison to what the patient's getting. So bear that in mind in terms of what we're trying to achieve here as well.
Yeah, thank you. And maybe a last question for each of you in turn, which maybe by way of also wrap up. So Josephine asked, who will benefit from geko? Question based on age, or doesn't it matter? Any contraindications? So maybe I'll go around Dr. Evans, Dr. Stacey, and Dr. Sibbald, and maybe ask you to respond to that yourself, maybe by way of wrapping up. Dr. Evans?
Okay. Yep. So my use of the neuromuscular pump activator or geko would be that special case, the sickle cell, looking at blood flow and edema. I've used it. I've started using it a lot more recently on patients that could not be revascularized and have ischemic pain. And I'm not sure I've got better healing, but the pain scores have gone down and the use of pain medication has gone down. So I again look to using it in patients that would benefit most from it in terms of reducing the swelling, improving the blood flow, and I think more and more figuring out how it can fit into the pain management piece of complex wounds.
Thank you, Dr. Evans. Dr. Stacey?
Yeah, so firstly, age is not a contraindication, just to put that on the table. That was part of the question. In terms of the types of patients, so I'll just go through the different types of wound problems that I'd use it for. So certainly venous leg ulcers, like we've got an enormous amount of data on, where its benefit is with venous leg ulcers. What the Canadian consensus statement put forward is to use it in patients who can't tolerate compression or can't use compression, so they may have some arterial disease. So use it then often in combination with a lower level or a light form of compression. And then if it's not healing when you're using your optimal compression, then add it in then. Now, I think ultimately, because of what the data are showing us, we will likely start to use this eventually with more patients. And also particularly with patients who've had a wound present for 12 months or longer, because those patients are in a long-term trajectory of the wound not healing. And there's some very good data that those patients' ulcers improve, sometimes using it more continuous than just for 4 weeks. And then the other groups of patients for whom, I've used it a fair bit is patients with either large or small vessel arterial disease where we don't have reconstruction options, or we have and we've exhausted them, or if they've got, just microvascular disease. It definitely can help with pain. It can also help with the wounds healing. And that translates into those patients with diabetic foot ulcers who also have some arterial disease as well. So I think, the sort of bottom line is if you've got a patient with a lower leg wound that you've done all the appropriate treatment, treating the cause, using compression, offloading, fixing their arteries, and they're still not improving, you've got this as an option to add to that patient to try and help things to heal. And, and I'm hearing that, soon we'll have that available in Ontario on the formulary, and it's available in other parts of the country. So it's something that is becoming more accessible to all of you as clinicians to add to that patient. So, I think there's very much a role for using this, and it's so fortunate that we're getting more access to this device.
Excellent. Thank you, Dr. Stacey. Dr. Sibbald?
I would second the comments that have already been made. I think that some of the other things that are worth looking at, people that have anemia that is not correctable, like the sickle cell, and if they get too many transfusions, they get iron overload and they get other complications of the actual clinical condition of actually increasing surface oxygenation and hopefully facilitating healing. I think we need more data, but I think there are other uses for this device that will become apparent as we go forward. And it looks like it can build up some muscle mass too.
Fascinating. Thank you, Dr. Sibbald. Jeff, was there anything that we haven't answered that you wanted to pose to our esteemed panel of experts before I wrap up?
Yeah, there were a couple of questions raised in the chat. Josephine Rivera, I'm not sure if we answered your questions. They went into the chat instead of the Q&A. But if they haven't been answered, if you please let us know. There was one question on availability through NIHB. That's non-insured health benefits, which is Indigenous Services Canada. We're actively engaged with them, and we expect to have an answer by November. I think by November timeframe, it will be an equity issue, and I'm pretty confident that NIHB will come on board. Another question was asked as it relates to insurance. Insurance is often determined by your employer, and therefore we can't answer that directly. And Ontario Health at Home, we're anticipating in the next week or two that we'll get confirmation that the device will be added to the formulary. So we can't give you with absolute certainty at this point, but it should be available in the not too distant future. But other than that, thanks for a great talk, Dr. Stacey, Dr. Sibbald, Dr. Evans. You've delivered the most extraordinary series of webinars. I can't believe the interest. Well, I shouldn't say I can't believe the interest. I'm actually not surprised by the interest. What came out as was intended as a compliment came out as an insult. Wasn't meant that way. You guys are truly extraordinary, and to have the three of you on a call is amazing. And grateful for your time, and I look forward to more in the future. So thank you very much.
Okay, no, I echo that too. So yeah, I would like to thank Dr. Evans, Dr. Sibbald, and Dr. Stacey. Thank you to you, Jeff Forney, for sponsor as Perfuse Medtec. So for everyone attending, you'll receive an email in the days after the webinar with a link to the survey about it, a certificate of attendance, and on-demand link to access the recording. Thank you to Troy Curtis and the team at NSWOCC. There is one more webinar this month on Wednesday, June 24th, and 1 hour earlier. Stop sealing in the problem, advancing incontinence-associated dermatitis protocols beyond moisture management for pressure injury prevention, with presenter Brittany Butt and sponsored by Ergo Medical and Canadian Pressure Injury Advisory Panel. So please come back for that. So I'm John Gregory, and on behalf of NSWOCC and the WOC Institute, thanks to our speakers, Dr. Evans, Dr. Stacey, and Dr. Sibbald, and sponsor Perfuse Medtec. And thank you for attending. We look forward to seeing you at the next webinars. All right, bye for now. Good night.
Good night. Thanks, everybody.
Thank you. Bye for now.